Today, I would like to talk about to stratify risk of prostate cancer with blood and urine biomarkers and their role in the current MRI era. And I'm Peter, and growing up in Hong Kong, I had my medical school in Hong Kong. I had some training in the UK, and then my PhD in Erasmus University in the Netherlands, and I'm currently an associate professor and also the president of the Hong Kong Urology Association. Right, so I've no particular conflict of interest related to this presentation. So I come from Hong Kong, and it's part of Asia. So I'm going to share some of my Asian perspectives in this talk too. So please bear with me. So prostate cancer has been the #1 male cancer in the Caucasian world, but however, it's like between like the third, fourth, fifth, or sixth common male cancer in the Asia Pacific region, except Australia and New Zealand, because they're actually Caucasian. But the numbers are actually growing very quickly, and in many parts of Asia. And the more worrying thing is that in Asia, we're actually having more stage 4 metastatic prostate cancer upon presentation of prostate cancer. I checked the data on the SEER publication in the US. So it was like 2008, 11% metastatic at presentation. It rose to 17% in 2018. Not sure whether that's related to the USPSTF recommendation. Please educate me if it's yes or no. In UK, it was around 15%, according to NICE figures back in 2019. In Hong Kong, it is actually 32% in the latest figure in 2021. And in mainland China and in some other parts of Asia, it's actually more than 50%. So it's not good. So to have a lot of metastatic prostate cancer, this is a disease that cannot be cured. And this is a figure from Hong Kong in the past 10 years. Prostate cancer is actually the cancer with the highest increase in the incidence over the past 10 years, compared with like even breast, colorectal, or lung cancer. But what is more worrying is the proportion of stage 4 disease. When we look at the incidence, it's we thought it's related to like screening or more widespread use of PSA and diagnosis of more low-grade or low-stage cancers. But when we look at the figures, which is capturing 100% of the prostate cancer case in public and private hospitals in Hong Kong, the proportion of stage 4 disease actually increased from 24% to 31.5% in recent years. So it's actually a genuine increase in advanced prostate cancer instead of just low-grade cancer. And from some epidemiology studies and some statistical predictions, in 20 years' time, prostate cancer incidence in Asia will double in 2040. So a little bit of a couple of slides and news. Like in Singapore, actually, Prime Minister Mr. Lee actually has prostate cancer, and he was operated in Singapore. But from my friends in Singapore, they said they do not get a big boost in terms of resources in prostate cancer, unfortunately. And just one day ago, one day before, I think we saw the news that King Charles III, in UK actually is announced to have diagnosed with cancer after surgery for BPH. So and it's said to be a form of cancer, but they have not specified. I hope it's not lymphoma, as a colleague have just mentioned. So let's go back to the topic. So I have a few slides on prostate cancer screening, which I would like to share my personal thoughts on. Now, it has been more than like 12, 13 years, like since the publication from the RSPC and PLCO trials in New England Journal of Medicine. We use a PSA in screening early diagnosis of prostate cancer, with the RSPC European trial showing a reduction in metastasis and prostate cancer deaths. But however, it was associated with a lot of investigation, overdiagnosis of low-grade prostate cancers, and subsequently overtreatment in quite a number of patients. So as just a recap, the ERSPC was first published in 2019, and the latest one is actually not 2014, but there's another paper published more recently. It has resulted in 21% reduction on prostate cancer mortality and 30% reduction in metastasis at diagnosis. However, the number needed to screen initially was 1,410, which was considered to be too high. But actually, when we look at the ERSPC data with the longer years of follow-up, up to 11, 13, and then 16 years data, the number needed to screen with long follow-up reduced to 570 to reduce one prostate cancer mortality. So I looked up previously in breast cancer data, which now breast cancer has been screened in a lot of countries as a national policy, in addition to colorectal cancer, cervical cancer, etc. So when we look at breast cancer data from a publication at BMC Medical recent years, the number needed to screen with a mammogram for breast cancer is somehow exactly 570. So it's actually the same to reduce one cancer mortality. So it just gives us, thoughts that like, well, should we actually screen for prostate cancer? And then, of course, when we look at the PLCO, then the answer seems to be no. But when we see this, like there's no, in the PLCO arm screening and control arm, there was no prostate cancer deaths even in the latest updated data. But we must note that, like in one letter to the New England Journal of Medicine published many years ago, back in 2016, according to some post-study surveys, actually it is very likely that more than 80% of men in a control arm in the PLCO trial has been tested before or during the trial with the PSA. So in a way, this is like comparing apple with apple. So it's it's not really an evidence that we should put into consideration when we consider whether we should screen prostate cancer with PSA. Now, there are some subsequent systematic review showing that, like, per 1,000 men screened, there will be increase in 18 cases of prostate cancer, 14 localized disease, and but 3 less advanced disease. But however, there are risks associated with it, including like sepsis, requiring hospitalization, 1 out of 1,000 per 1,000 men screened. More urinary incontinence and erectile dysfunction related to treatment, of course. But however, when we look at it, when we consider whether we should screen for prostate cancer with a PSA, it was the discussion. We still, from guideline panels and including the USPSTF, is the evidence looking at that is PSA and then a 6-core random transrectal prostate biopsy, and that of course led to a lot of problems. But unfortunately, we don't do that anymore. So we now have like various risk stratification tools to help us to select men who are at a high risk of clinically significant prostate cancer before we offer a prostate biopsy to men these days. And not to mention that when we offer prostate biopsy now, more and more people actually move on to transperineal route of prostate biopsy, which actually almost eliminated post-biopsy infection and sepsis. Just a note that in Hong Kong, actually, we switched since 2019 from transrectal to transperineal in the hospital. And now in the whole of Hong Kong, all public hospital and private hospital, more than 90% of the urologists actually change completely transperineal biopsy. So it's actually a worldwide trend. So, but looking back into the evidence on why we use MRI to look for finger-significant prostate cancer from the main precision trial, which shows that the MRI used in detecting prostate cancer would improve the detection of significant cancer from 26% to 38%, and it reduced unnecessary biopsy by 28% and reduced low-grade prostate cancer diagnosis by 13%. And this is, of course, a lemma trial published by Chiu back in 2018. And there are a number of and when we look at like what are the, besides MRI, what are the biomarkers? So we finally reached biomarkers in this talk. And what are biomarkers that could actually reduce unnecessary biopsies, in the modern setting? So there are a number of tests which has been approved like since many years ago, which has been used since many years, like Prostate Health Index in US back in 2012, the Prostate Score a few years later, the PSA3 urine test, which was approved, I think it's 2011. And more recently, there's another urine test called the Michigan Prostate, which is called my Prostate Score now. I will elaborate on each of them subsequently. There's also the SelectMDX test developed in the Netherlands, the XODX test, another urine test, and so on. So we have a long list of tools that can help us to stratify the risk of prostate cancer. But please note that most of these early evidence and landmark evidence is actually based on patients, or based on, in that period, there was actually a pre-MRI era, which a lot of the evidence based on a systematic 10 to 12 core trust biopsy. And I'm going to look at every one of them. So when we look at risk calculator, which frankly speaking, in real life practice, not many urologists, as far as I understand, would actually use the risk calculator that much. But in fact, they are actually very helpful, because if we are basing our biopsy decisions only on the PSA, and then you have no other biomarkers to help you, then these risk calculators actually do help. When I was a trainee, we discussed like a PCPT risk calculator and the RSPC risk calculator, and this is a more contemporary calculator developed from a number of Caucasian cohorts, including US. I believe there's a European course too. So it's a Prostate Biopsy Collaborative Group biopsy risk calculator, and it was shown to in internal validation and modern application external validation to be better than the PCPT risk calculator version 2.0, despite just a few percent of AUC difference. This PBCG, when we look at the decision curve analyses across the whole threshold probability from like 5% to 20-30%, there was an obvious net benefit over the PCPT risk calculator. So if we're going to use risk calculator, we can consider PBCG instead of the PCPT. The other risk calculator I must mention is because I'm actually trained in that center in Rotterdam, in Erasmus Center, and my PhD supervisor actually developed this risk calculator, Professor Nick Rubel and Professor Chris Ruder. So the RSPC risk calculator is currently in the web or the app form. This is the app screen cap, which it's unique. You can download the app. I think that costs you $1 for some reason. And so it would be easy to use, and it would be interesting to look at. Like nowadays, the name is changed from RSPC to Rotterdam, and I believe this is related to that. Most of these, actually, all of this data generating this risk calculator is actually from Rotterdam part of the RSPC instead of the whole RSPC. So that's I guess there's some discussion between the different European RSPC centers that talk about that. Some years ago, I actually worked on this RSPC risk calculator and applied that to more than 5,000 men in Hong Kong with biopsies, and we realized that in Chinese men, in Asian men, the same PSA and US using the same risk calculator actually overestimated the actual risk of prostate cancer or high-grade prostate cancer in Chinese men. So we kind of did some simple recalibration and subsequently arrived in a good calibration in another validation cohort of more than 2,000 men in the hospital. And at this risk threshold of like 10% high-grade prostate cancer, we're talking about Gleason 3+4, about 42% of biopsy could be avoided using this simple risk calculator. So much for the risk calculators that we don't usually use. I'm going to move on to the real biomarkers. The first of which would be the Prostate Health Index, which I've been working on quite a lot in the past decade. and we have it's actually currently available in so I believe all of you should have heard about it or even have used it before, but for the few of you which have forgotten the origins of it, it is actually a small part of the free PSA, the -2 Pro PSA, now we call it P2 PSA, which is actually the key player in Prostate Health Index, which is the biomarker found to be comparatively more specific to prostate cancer compared with other precursors of PSA or pre-PSA or total PSA. So these non-functioning precursors of PSA are actually produced in prostate cells, and actually together with the PSA is also released to the bloodstream, so we can actually measure that. And the Prostate Health Index is P2 PSA divided by the free PSA multiplied by a square root of the total PSA. So it looks complicated. And in reality, in fact, when we look back at the studies with comparing the percentage of the P2 PSA over free PSA with the Prostate Health Index itself, in fact, the performance is actually similar. But the Beckman Coulter company actually commercialized that with the Prostate Health Index. So nowadays, all people use the index instead of the P2 PSA percentage. And as said, it's FDA approved since more than 10 years ago. The men with more than 50 years old, with the PSA of 4 to 10, and then normal digital rectal examination. So this was the first PHI study performed in Asian men, actually headed by my boss in the department of university. And this was published back in 2015, and showing that the performance of the PHI was actually similar to that in Caucasian cohorts, with the AUC of around 78%, compared with 63% in PSA density and 55% in the PSA, which is quite similar to other cohorts. And with this 90% sensitivity for high-grade cancer, almost 50% of biopsy could be avoided with using this simple Prostate Health Index test. Subsequently, I worked with some other cohorts, so 5 other hospitals in Asia and 4 hospitals, including Germany and France, to look at a comparative evaluation of the performance of this Prostate Health Index in different ethnic groups. And we realized that the first thing we look at here is in men with a PSA of 4 to 10, and just to remind you, the PSA density is actually identical in these 2 cohorts. And the incidence of prostate cancer is 52% any grade and 21% high grade, like lesion 7 or above, for in the European cohort. But only 13% Asian men actually have any grade prostate cancer, and only 5.7% of men actually have high grade prostate cancer with the exactly same PSA, median PSA, and median PSA density. So we are kind of looking at some ethnic differences here. And when we also look at the performance of the Prostate Health Index, this also showed some considerable differences. When you look at any grade prostate cancer here, and in yellow, the high-grade prostate cancer, there is actually a considerable difference, especially for PHI, like 35 to 55. It was like 27% in European cohort and just 12% in the Asian cohort. And therefore, currently in Hong Kong Chinese men in Hong Kong, we're actually using a different reference range for PHI compared to the one that is used in Caucasian. And we could actually reduce more unnecessary prostate biopsies compared with the European cohorts. Up to 56% of the biopsies could be reduced. So this is the Prostate Index test, PHI test report in the public hospitals in Hong Kong. Currently, it's free for the patients. So it's maybe it's equivalent to the reimbursable in the US since 2016. So it's currently more like a reflex test. And in fact, the PHI test can be ordered by specialist nurse in the nurse clinic before the urologist first see a patient. So when we first see a patient with elevated PSA, in the proportion of patients that has been seen by our nurses, we already have the PHI test on our screen, before we even talk to the patient. And looking at the report, you can see that there's a reference range for Caucasian in the landmark study published in 2011 by Professor Catalona. And the risk of, say, the risk of cancer of the PHI of 35 to 55 would be 32%, and it was 22% in Hong Kong Chinese men. So we're currently using the reference range below when we talk to the patient. And this is an audit data of more than 2,500 PHI tests. This is on a peer review. That you can see that, in fact, more than 80% of the men actually had a PHI of less than 35 in the men. So most of the men with elevated PSA actually have a low PHI. And so even if we use a low cutoff of 25, a very low cutoff of 25, we could actually avoid almost 50% of prostate biopsies in Asian men. And when we look at the real life practice, so do the men, really, or do the urologists really look at it and change their practice? So there's a considerable difference in terms of the percentage of the patient that eventually operate a prostate biopsy. Of course, again, this is kind of the pre-MRI era. This is from 2016, 2017 data. We only had the MRI in our system since like 2018, 2019. And we also showed that in a prospective specimen that PHI is associated with more aggressive prostate cancer, PT3 or Gleason score 7 disease. There is actually a number of publications, 3 to 4 publications talking about this topic, but I'm sorry that I quoted my our own paper. And when the FDA approved the PHI test for PSA of 4 to 10, we actually also looked at the performance of PHI in men with PSA of 10 to 20, because we realized that the incidence of prostate cancer in Chinese men at a PSA of 10 to 20 was around maybe 20-something, 30% or 35%, which is actually similar to the detection rate of prostate cancer in Caucasian men with a PSA of 4 to 10. So we looked at that and we realized that the PHI also was able to differentiate men into high risk of prostate cancer and to very low risk of prostate cancer if in men with PSA of 10 to 20. Just to remind you that the median PSA in this study was 13. So I would say it applies to men with a PSA of 10 to 15 more instead of 15 to 20. So in a way, if its PSA is more than 15, we kind of biopsy them anyway. So much so for the PHI test. I'm going to cover the 4K score too, which I don't have access to. So unfortunately, I don't have personal experience or my do not have my own data on the 4K score. But this is actually FDA approved since a couple of years ago, and it comprised of the total PSA, free PSA, intact PSA, and HA2. Please note that this is in combination with clinical factors including age, DRE, prior biopsy status, in arriving at 4K score in predicting aggressive prostate cancer Gleason 7 or above. So that was not any grade prostate cancer, but Gleason 7 or above from the beginning. There was not many comparative studies between 4K and PHI, but there was one study published in 2017 showing the AUC of 4K and PHI was pretty similar for high-grade prostate cancer of between 81 and 82%. And from my understanding, the 4K score is only available in North America and Europe, and I currently still have difficulty in locating any distributor in Asia, and so it is not very applicable. I actually talked with the COO of from not this the other SelectMDX, but I talked to the one of the principal investigators in the 4K score, but at the time there was just before COVID, and unfortunately didn't have a chance to validate that in Asian men. So it's mainly validated in Caucasian men for 4K score. From Dr. Son, I believe last year you actually had a talk from Professor Eric Klein on this ISO-PSA test, so I'm not going to deal with that. Again, we don't have this test. This test was shown as ISO-PSA test, which is actually, I believe, is commercially available in the US now, using an ISO-PSA index risk threshold of 6.0. And this 6.0, it has a negative predictive value of 92% based on the landmark studies for high-grade prostate cancer, and I believe the positive predictive value is around 50%. So let's move on to the urine biomarkers, which are here. There's a long list of them. The first of which would be the PSA3 test, the prostate cancer antigen 3 test, which is a famous test, which is, I believe, was the first, popularized biomarker for prostate cancer detection. It's utilized a post-prostatic massage urine, detecting the PSA3 to PSA mRNA ratio in the urine, and they need to catch the first 20 to 30 mils of the urine after the attentive prostatic massage, three strokes per lobe. And we actually did a local study in Hong Kong, and I realized from my personal view of it, it's actually quite uncomfortable for the patient to do this attentive prostatic massage, and there is considerable difference in how hard you press onto the prostate, and this might, in my understanding, might affect the value of the PSA3. But anyway, it's been FDA approved since 2012 in men with at least one negative prostate biopsy at that time. I think it's still not yet FDA approved for biopsy naive men. And so this, I think we all learned from this PSA3 experience that when we try to get FDA approval, we should get the approval right first instance, because I think the company failed to get a revision of the FDA approval for biopsy naive men, despite some further evidence supporting that too. Yeah. In this one of the big studies looking at PSA3 here, you can see the AUC was up to 76%. But however, this has not been replicated in most other studies, and a lot of other studies only reviewed an AUC of around between 65 to 70%. So yeah. And in some head-to-head comparisons of PSA3 with PHI or PSA3 with SelectMDX, PSA3 was actually inferior, particularly to SelectMDX and also to PHI in most other independent cohorts. And I just mentioned SelectMDX, which is another post-prostatic massage urine test developed in the Netherlands, including two urine mRNA, the HOXC6 and DLX1. Only the two markers have an AUC of 76% in predicting high-grade prostate cancer, as in all, or not all, but most biomarkers, combining with some clinical factors, would usually improve the eventual predictability and AUC. So the SelectMDX score is actually a combination of these two mRNA and 5 clinical factors, and arriving at a much better AUC of 86% in the validation cohort. I attempted to collaborate with the SelectMDX, and we actually had some initial agreement, but then since COVID, we actually stopped, and the COO actually left the company, so then I didn't have a chance to try that. But the strength of it, as advertised, was the high negative predictive value for high-grade prostate cancer, up to 98%, and it shows a profile to see if there's an increased risk of aggressive prostate cancer in both biopsy naive and negative biopsy men. This is the same. So the AUC of this SelectMDX in some external validation cohorts was up to 80. Well, depending on ERE, it's between 80% to 85% for high-grade prostate cancer. So it's pretty good. But I said it is not widely available everywhere in the world. So and the cost of it is actually not cheap. So to my understanding, it is around I think at least 400 or even more US dollars, in 100 to 500 US dollars for that. and in fact, just for in comparison, why we use PHI in Hong Kong, because when we use in bulk purchase, the cost of the PHI is less than $100 per test. So this is a bit more affordable and definitely more cost effective if you're looking at the test with similar performances. The next one would be the Michigan Prostate Score, which is now renamed as MPS, the My Prostate Score. From a recent conference in the US, I realized it's actually there's a booth promoting that, but I believe they have not put into full commercial release, but they're going to do that very soon. So it's another post-DRE urine. So again, it's not very convenient for most urologists and the patient to have a post-DRE urine. So it's a combination of PSA, PCA3, and the 10+2 ERG fusion gene, which comprise of the multivariable risk score with the AUC of combination of 75. So it's a modest, 75%. Although it's not a head-to-head comparison, when we look at SelectMDX, 4K score, PHI, the My Prostate Score didn't give a very impressive AUC in terms of the Gleason 7 or about cancer. And using the MPS, My Prostate Score of less than 10, it has a high negative predictive value of around like 97 or 98%. But when we look at the specificity, it's around like 30%. So again, when I look at a negative predictive value, you look at all these tests, it's actually very easy to arrive in like 90-something% or 95% negative predictive value, but the difficult part is the specificity usually. So again, it's inconvenient to do these prostate massage. So then subsequently we have a few other tests which do not require this prostate massage, including XODX, Sentinel, and one of the tests you may not have heard of, it would be the urine spermine test. So the XODX urine test is a test which combines the ERG, PSA3, and the SPDEF. Now this is actually used to kind of normalize this PSA3, and this XODX panel is also combined with the PSA, age, race, family history, etc., to detect the Gleason score 7 or about prostate cancer with a modest AUC of 71%. Reducing a modest percentage of 27% of the biopsies, negative predictive value of 91%. To my understanding, it has been FDA approved since a few years ago. What do I want to show? So the specificity was around 34% with a cutoff. And what we should learn from this is actually published in the journal Oncology. So in adult patients, like less than 400 patients. So it's a nice effort. So the other test which surprised everyone a lot in recent years would be the Sentinel urine test, which is a urine exosomal RNA test without the need of DRE. This is, I think it's published from Dr. Lee Wang, Dr. Sorokin, and also you can see Professor Lawrence Kloss in co-author. It gives extremely high sensitivity and specificity, more than 90%. So the specificity would be the key. Looking at the 90% for high-grade prostate cancer, but however, this is more like using a case control design in kind of validating that. So I believe they're pending some external validation in biopsy and radical prostatectomy specimen. So they used 235 men in the discovery cohort in arriving in almost 200 urine exosomal non-coding short non-coding RNAs and some microRNAs in arriving in this combination of large panel of urine exosomal RNA, small RNA, to have this test, and it shows extremely good differentiation between like cancer, no cancer, high grade cancer, and low grade cancer. So it's really advanced, and this is the kind of, I would coin it more a case control internal validation thing, with the AUC of 97%, which is if it is shown replicated in external validation, it would take away all other biomarkers. But of course, we're waiting for the results. So now I'm going to briefly talk about the urine spermine test because it is developed in Hong Kong between a collaborative effort from my institute and the other university, Hong Kong Baptist University in Hong Kong, using urine spermine. So what is urine spermine? Now, I know nothing of it before 2015. When we worked, when a group of chemists actually discussed with us, whether this would help, because this evidence is not new evidence. The laboratory evidence of like urine, not urine, but the spermine having some sort of association with the prostate cancer has been described more than 25, 30 years ago. But then some early studies did not arrive in a positive result for prostate cancer diagnosis, so it actually abandoned before 1990. So it's a long time ago. But then what are urine polyamines? They're actually kind of reversible things. This is physiological. So this exists in every single cell. Not so much in the blood, but much more in the urine. So it's actually in the highest level of these polyamines is actually in prostate tissue in human, and it's involved in the secretory function in prostate epithelial cells. And some laboratory studies actually show that the spermine level is actually lower in prostate cancer tissue compared with benign tissue parts in the prostatectomy specimen. So we did a pilot study looking at the urine spermine level. We actually looked also at the purchasing and the spermidine, so all three of them, but only spermine actually stood out as a more differentiable marker. And this test without prostatic massage results in a lower urine spermine at that time. So that was only less than 200 patients. We expanded our cohort to 600 patients and published our first study on that prospective study on this 2021 on the PSA of 40-20 Chinese men, 30 mils of urine without prostatic massage, showing that the lower the urine spermine, the higher the risk of any grade cancer, 3+4 cancer, 4+3 cancer. So it's kind of statistically significant. So we show that low urine spermine level is associated with high grade prostate cancer. And again, we would love to use that alone, but unfortunately, using that alone, urine spermine alone, performance is not good enough. So we actually combine that with some other clinical factors, including age, DRE, PSA, prostate volume, to arrive at the urine spermine risk score, and with the AUC of around 82% to 85% for high-grade prostate cancer. And this was much better than the PSA density or other informations. We were able to demonstrate a reduction of 36.7% reduction of unnecessary biopsies and 90% sensitivity, and a negative predictive value of 95.4%. And avoiding diagnosis of almost a quarter of low-grade prostate cancers. And we did another external validation in another prospective cohort in Hong Kong of almost another 595 consecutive men with elevated PSA of 4-20, showing that spermine risk score had an AUC around 79% for Gleason 7 cancer, which was better than the PSA density of the PSA itself. And a reasonably good calibration, and it's actually commercially available only in Hong Kong now. But I'm not involved in any of the company, and I have no conflict of interest at all. But the company is trying to license that in Japan too, because we actually with another Japanese group, we published together an external validation of this urine spermine risk score in Japanese men, published last year, less than a half year ago, showing that there is actually similar performance in terms of the AUC. Yeah. So, but then after talking for so long, so the topic is in the era. I mean, today is in the era of MRI prostate. So we now offer MRI prostate for almost every single man with elevated PSA. So how useful are these biomarkers? Do they still have a role in this era of when we do MRI for every single patient? Now, I think the discussion is, in subsequently we are thinking about like we're having 100% MRI, but towards the end of my talk, we'll also discuss can we avoid some MRI in some patients with elevated PSA. So if we have the PSA, then how do we combine with with the MRI in terms of like risk calculators, PSA density, or all other biomarkers that I've just mentioned in the presence of MRI. Now, this is the EAU guideline, which the latest version in 2023 actually included PSA density in combination with the MRI in deciding whether a patient should proceed to a biopsy. Now, this is grade group 2 or above cancer, and the remarkable thing is for Paris-3 disease, Paris-3 lesions on the MRI, there was this a very remarkable difference in terms of a higher PSA density of more than 20% or more than 15% compared with that low than 10% in terms of high-grade prostate cancer. So only 4% if the PSA density is less than 10%. So it is a very cheap and readily available way of differentiating men or guiding our biopsy decisions. Whereas for Paris 4 and 5, I mean, the significant cancer rate is already so high that there is no place for the PSA density. So so there's some room, but for Paris 2, if it is a very high PSA density, then maybe we should offer a systematic biopsy, even if the MRI is considered Paris 2. So there are a range of publications that combines different things with the MRI in stratifying the risk of significant prostate cancer. One of which is highly cited, which is the one written by my colleague in Erasmus in Rotterdam, Dr. Arnold Alberts, in collaboration Monique Rubel and myself. It's a paper combining the Rotterdam European the ERPC calculator with the MRI finding, and they realized combining this risk calculator with the MRI would improve the AUC to 84% instead of just 74%, and could further reduce up to 1/3 of the biopsies at 90% sensitivity. But again, risk calculators, when you need to go up to the app or go onto the website to input all the figures into it, then no one will use that. So as a matter of fact, this ERPC would be the Rotterdam group. So and of course they're not friends with the Amsterdam people. And in fact, in the whole of Netherlands, probably only urologists in Rotterdam would use this risk calculator, but not urologists in Amsterdam. So you can understand how bad risk calculators can be generalized. So when we realized that Paris-3 lesion would be the gray zone and would be the area, the battlefield that the biomarkers may play a role, then we look at different combinations. One of the evidence would be from PHI, the Prostate Health Index, and here there's a PHI. There's also this PHI density, which PHI density is just like PSA density is a PHI divided by the prostate volume, which is readily available because the men already have an MRI. So, and we published our multi-center Asian experience in July last year, showing that the PHI density compared with the PSA density actually is much better in Paris-3 lesion. And difference in AUC is quite significant at 10%. So we realized that using PHI density, because PHI in our locality is kind of free for the patient, it's readily available. So we are now using this to stratify men. So looking into the table, highlighting on the Paris-3, here there are like 455 men. The PHI density of less than 0.4 or less than 0.8 would have Gleason 7 cancer rate of less than 10%, but it's much higher if it's more than 0.8. So I would suggest if the PSA density is less than 0.8 for Pirates-free lesion, we could actually avoid a biopsy. And when we look at it, the denominator here is 181, 134, compared to 77 and 63 for higher PHI density. So with this in mind, if we avoid offering biopsy for men with a low PHI density of less than 0.8 in men with Pirates-free lesions, we could save almost 70% of biopsy in this group. And we are not the only group in Asia to publish our experience. There's another Korean group which published the experience with PHI density in combination with the Pirates-free lesions too, using a very similar cutoff. So I would say this is actually replicable and reducing a similar proportion of biopsies. And another Korean group, so not the same Korean group, also published another PHI density paper with the MRI showing a reduction of about like 48% biopsies, missing only 5% significant prostate cancers. And the cutoff is surprisingly similar at 0.88. So it's between 0.75, 0.8 something. So I think this is pretty confirmed. So much so for the PHI, as I'm heavily biased, working a lot with PHI, but the 4K score, which I have no experience with, also have a big study of more than 1,000 men with MRI prostate and a 4K score performed, and showing that combining MRI and 4K score actually resulted in the largest biopsy reduction of 37%. If we only biopsy Pirates 4-5, or if only biopsy those high 4K score of more than 20%. But the devil's in the details, because when you look at it, just MRI alone would already avoid a 33.7% biopsies using, and the combination of 4K plus MRI is 37.5. This is a slight difference of 3% biopsies avoided. Whether this is significant, whether this is justifiable to justify the cost of $600 as quoted in this paper. To add, this is debatable. When I talk about like the PHI test in my locality is $100, and you can imagine, if I have a few tests available to me that is equally effective, then the cost would play a big part, or the availability would play a big part. But anyway, in this study, when we look at the AUC, there was a big difference between the 4K plus Pirates, which is 85%, compared with just MRI Pirates of 77%. But we must also note that for all these Pirates score, AUC, MRI, it's heavily messed up with the Pirates-3, because Pirates-3 has a relatively low rate of significant cancer, which if we use a cutoff of 4 to 5 instead of 3, this AUC would be much better. But of course, we would at a cost of missing more significant cancer too. I included also this study with the SelectMDX combined with the MRI published from Mr. Tavari's group. But before I talk about the results, it's only the biopsied men in this cohort is 65 men, so I would consider this as a very small study. But if we look at, but what I want to look at is looking at the nomogram here. You can see the Pirates-3 weighting is very close to 0, which is close to, I would say, like normal MRI, but 4 to 5 is like on the other end, far higher score. So in the weighting, it's like Pirates 4-5 would have a like 5.5 score in the weighting, but Pirates-3 would have a 1. So Pirates-3 is in a way not contributing a lot in the score. So it wouldn't be very helpful if we include only Pirates-3 patients. And the more recent My Prostate Score MPS also have a study combining with equivalent Pirates-3 MRI and showing that the AUC for predicting hybrid cancer, as again in this Pirates-3 population, is only 121 men, so it's relatively small. The AUC for PSA was 55% in this group, 62% for PSA density, and 73% for the MyProstate score. So I talked about the urine spermine test, but in fact, that urine spermine risk score was also validated in Japanese men with MRI done. And when we combine that with the pirate score, it is also outperformed. When we combine, add the pirate's finding to the urine spermine score, it improved the AUC from by about 4% to up to 86% when we combine that. And again, in Japan, the MRI has been approved since last year for all men with PSA. So towards the end, we'd like to discuss, like, MRI is good. We can locate our cancers, hydrofocal therapy, and a lot of MRI scans. But are we doing too many MRI scans? And can we do something with these biomarkers? This is actually one small publication from my group. As part of the early experience, 1,500 screened men in our local Hong Kong prostate cancer screening trial. You're looking at a combined row of the Prostate Health Index and MRI in the screening cohort. And we have MRI for every single man with elevated PSA. And including, when we look at the men with a lower PHI of less than 35, most men with, more than 80% of the men with low PHI actually has a Pirates 1-2 MRI. And when we look at the number of MRI that was needed to diagnose one additional grade group 2 or above prostate cancer was 94. So 94. So you need to do 94 MRI to diagnose one more high-grade significant cancer, and it's only 3+4 disease in that case. So it's whether it's cost-effective, probably not. But for a high PHI of more than 35, we only need to do 20 MRIs to diagnose one additional grade group 2 cancer. Now, there's a catch to it, because in this study, we do MRI targeted plus systematic biopsies. And in fact, the systematic biopsy already reviewed. We do a transperineal systematic biopsy of about 18 cores. And we actually, in addition to the MRI targeted biopsy, so we were able to diagnose most of this significant cancer with a systematic biopsy under local anesthesia. This is another paper from Korea, a combination of the PHI that could reduce about 20% MRI at the risk of missing 6% significant cancer. And there is another ongoing screening trial, I believe in Finland, if I'm not mistaken, by Dr. Holmgren, actually one of the main co-authors in the RSPC study, and of course Professor Renico too. They're incorporating this 4K score before MRI in this new pro screen trial. So this is estimated that about 30% of men here after 4K score would be able to avoid an MRI. So the screening pathway actually stops here if there is a low 4K score and not proceed to even an MRI. So this possibility that about 30% of them would be they could avoid an MRI, but this is ongoing trial. Another famous marker, the Stockholm 3 score, which I have not mentioned so far, but I think I must include that. It's to me, it's a rather complicated combination of plasma protein biomarkers, including PSA, free PSA, intact PSA, HA2, MSNB, MIC1, and 232 SNPs, polymorphisms, and plus clinical variables, age, family history, previous prostate biopsy, etc. So this is complicated to me, and it's not widely available in the commercial market. Now, when we look at the AUC here, the PSA was 56% for high-grade prostate cancer, and the Stockholm 3 score was 0.74. So 74%. When we look at all the other prior tests, PHI, 4K, anything, would have better AUC than this. But of course these are again not head-to-head, so we need to look at it with some caution. But this nice paper in Lancet Oncology have showed that the use of the circumference score could reduce 36% MRI and 8% biopsy. So it could also reduce MRIs here. So so after I'm sorry for this long talk, but this is the summary slide. So I mean, these blood and urine biomarkers have shown to be quite useful in men with elevated PSA, and we could select men at high risk of significant prostate cancer, reduce unnecessary biopsies by like between 30 to 50%, and maybe we could reduce some MRI by maybe about like 20-30% in a very low risk men. And we could actually combine with biomarkers in guiding our biopsy decisions in these equivocal parent-3 gray zone things. But one thing to note that external validation in various ethnic groups is very important. And for my personal experience in using the same test in different ethnic groups, usually a recalibration or use of slightly different reference range is actually needed. Otherwise, you'll be overestimating or underestimating the actual cancer, despite having an identical AUC. So AUC is not everything. So and again, finally, and last but not least, of course, will be the cost concerns of each test. Would it be, when we have an excellent test, which the cost is like $500, $700 US, is it worth like incorporating that in a screening pathway? So finally, I like to use this call, like to screen or not to screen. That's not a question for prostate cancer. The question is, how should we screen for that?